And we're broadcasting live in our media presentation from the Dolph Simons Family Studio. Welcome back, and we're glad you're with us this morning. To my right again is Doc Hawk. Glad to have him back. He has safely journeyed back from Florida by airplane. He tells us. We're going to hear more about that trip in just a minute. On my left is Alan Greiner. I forget Alan's exact title, honestly. He kind of does a lot of stuff, but I know that he is the Chief Medical Officer or Medical Director for the Wyandotte County Health Department. He's got a fancier title than that, but that's close. And Jessica Callender-Rich, who's one of our outstanding geriatricians here at KU, working in a number of nursing homes, and I believe has just been named to a national commission to work on infection control in nursing homes. So we're going to turn to Jessica in just a moment to have her tell us a little bit about that, because that's a really big deal. So welcome to everybody this morning. Dana.
Hi.
How are we doing?
Hi. We're good. We're good. I'm glad to be back. It was a little harrowing in the airports. A lot of people wearing masks. Some of them were down below their nose and below their chin.
I don't think they're as good as that. I think the chin protective device isn't really part of COVID things.
No, I haven't seen that on the CDC guidelines. So we would really encourage it to be up above the nose.
Yeah.
And good form fitting. The airplanes, was okay. Everybody on the airplane was wearing masks. In fact, actually the airline that I was checking in at, they actually required anybody who was coming to check in to have a mask on, so that's good. I think it breaks down after that. But for the most part, again, was wearing mask, eye protection, using hand hygiene, not touching my face, not manipulating the mask or the eye protection, and hopefully it'll go well.
Yeah, and you got a little sun out there.
I got a little sun. I was physically distanced on the beach. It was easy to be apart from people. Did not eat at a restaurant indoors. There were one time outdoors and physically distanced, so that was good, and the rest of the time was just takeout. So really tried to continue the safe, healthy practices that we're doing here in Kansas City area.
All right, well, glad to have you back.
Yeah.
Dr. Greiner, good morning. How are things? Before, I know you've got slides. Alan always brings us slides, so I told you he's got a limit this morning, but he's going to talk about some slides. But tell us just a quick intro, and then we're going to switch to Jessica for just a moment. We'll come back to you for the slides after that.
So same stuff at the county level here in Wyandotte and really across the metro and the whole region around us here in Kansas City. Lots going on. It seems like it's kind of a continual rolling set of activities, watching data, trying to make decisions about changes in policies and ordinances, and then trying to attack new problems as we see outbreaks or new issues.
Yeah, a lot of work to be done. We're going to come back to that point in just a moment. Jessica, tell us a little bit about this national panel you've been placed on. That's a really big honor. Congratulations. We're delighted you're there. But talk to us a little bit about that and what the aims and objectives are.
Yeah, so first I should say thank you very much, and I'm really looking forward to getting to work on this. I think there's a lot of opportunity. I think we can all agree, actually, there's a lot of opportunity to really kind of improve the ways in which nursing homes can tackle COVID-19. The commission, while we haven't met yet, so I don't have the exact, plans and aims, I do know that the plan is to really conduct a comprehensive assessment of the response, to look at the way things have been done in nursing facilities and the way they could be done in order to make some recommendations that would really inform the efforts to safeguard the health and the quality of life of these vulnerable older adults. We're going to continue to battle this thing for quite a while, and there will likely be future threats that might be similar. And so there's an opportunity to really kind of drill down and create some better pathways.
Yeah, cool. Congratulations to that. How are things in the nursing homes right now? I mean, you are a frequent physician in several different nursing homes. So what's your sense of how the mood is for the folks who are there, as well as infection control?
I think the infection control practices have gotten only better over time. We really are learning and able to apply the things that we're learning from both locally and nationally. It's hard because despite all of those efforts, the virus is still getting in. There are still certainly smaller, but still outbreaks that are happening really all over the community. And it's partially challenged by the fact that, as everything has opened up, more of the staff and more of the people that are coming into the building as a necessity, as essential healthcare workers, are also perhaps more exposed in the community. And now we're sort of struggling with how do we continue to protect everyone as the nursing facilities look forward to ways in which they can reopen. And I think we're all still working through that at the state and county level, but certainly there are lots of questions.
Yeah, there are a lot of questions, but is there a sense that visitors will be allowed back in nursing homes in the near future?
So I think everybody is appropriately trying to balance the risks and the benefits of all that we are doing in COVID-19. And we have seen really on a large scale that while keeping all of the visitors out has probably done a really good job of preventing a lot of huge outbreaks, we've also seen individuals, really a lot of individuals, having some decline because their regular schedules have been disrupted. And so, on some level, there really has to be a way to reopen. I don't know that it's right now. I'm not sure that we have all the right things in place, because we really need to make sure that we have enough personal protective equipment and the right amount of testing and the right information to do it. But I do think ultimately, and sooner rather than later, it has to happen in some ways.
But yeah, love knows no bounds, but the doors of a nursing home being closed are tough, both for the residents and for the families. And you know, the hospital just opened its doors last week, I believe, or maybe it was a week, about 8-9 days ago. And you know, it is hard. It's hard to police. It's hard to make sure that you got it done right. But and I know that you'll be instrumental in making sure it does get done right. Alan, talk to us a little bit of controversy lately over the last 24 hours. Is a rising number of positive tests and hotspots in the United States. Is that because we're doing more testing, or is that because the disease is spreading more?
I think I think it depends probably on where we're looking at and what the testing capacity is. I think in the metro here, I think we feel like it's actually probably a little bit of an uptick, and so it's probably more due to some of the relaxation in the ordinances and the phases that we've gone through. Let me whip through my slides in 30 seconds here.
It's a perfect segue, right?
Exactly, and I'll show you what we've got here in the metro. This is our county comparison across the different metro jurisdictions, and you know, my concern, of course, is primarily with Wyandotte, but we're concerned about everything because everybody now with a lot of this reopening is traveling across county boundaries. Our rate of positivity across Wyandotte still significantly higher than the other counties.
And is this the rate of the people who you're testing?
This is determined by who we're testing, and I'll show you another one, I think, if I didn't take it out, though. Others are catching up in terms of the rate of testing that they're doing, which is great for the metro. So they should be catching up a little more on these numbers as well, and we'll see if that pans out. But we're still very worried in Wyandotte about what's going on, and we do have a very vulnerable population. And a lot like what Dr. Calendar-Rich mentions with folks in long-term care, nursing homes, we have a lot of sick folks in Wyandotte, so we want to protect them. But the deaths have been very stable, so that's good. Anthony, you could go to the next one. This is our rolling averages on new cases. You do see kind of what looks like an upward trend there in the last 10 days or so out to the far right. This data goes through Friday. We're really seeing this across the Kansas City metro, more probably in Wyandotte, Johnson, and then Kansas City, Missouri than others. Next one, Anthony. But the deaths, as I said, continue to stay stable and or declining on a 14-day moving average. So that's really encouraging. Next one.
Why do you think that is, just to say, why are we seeing less deaths but more positivity?
I don't think we know. I think we hope that it's related to the way we're protecting those that are most vulnerable, like those in long-term care or those with chronic disease.
But, you know, it's interesting. If you look at our patient population as an inpatient, we probably are a little younger and a little less complex, and so I think that's exactly what's happening. And so our length of stay has dropped from 13 or 14 days as an average length of stay down to 7 or 8.
Yep.
So I think that reflects a little different patient population being infected. So I think the important message for folks is the hospital numbers here may be a little lower, and it's around 20 today, I think, and But the number of admissions we're having is perhaps up a little bit, and the number of discharges just up because we have a little less sick population.
Right.
So.
And I think what we've done as a country and a region, it's been an effective intervention. This whole idea of shelter in place.
It did work.
And it worked.
It clearly worked.
And I think we continue to get the message to those most vulnerable that you probably need to keep staying home, and you need to protect your older relatives and neighbors and friends, and I think that's still happening, and that reflects in those hospitals.
Right. I think the pillars of infection control remain the same no matter who and where you are. Even wearing masks, but preferably not on your chin. Go ahead.
Right. So the positivity rate we're seeing has declined a lot here, although overall in Wyandotte it's still relatively high compared to others.
And when you say percent, this is a percentage of positivity for people who are actually tested.
Exactly.
Yeah.
Exactly. Although, again, most counties are seeing more and more testing. The next one, this one here, shows the rate of testing per 100,000 people. Everybody's getting it up past 5,000 per 100,000, which is good. And we need to. I think we're going to need to keep it around that rate for months and months and months to keep knowing what's going on. Next one, Anthony. Here's a little data on long-term care facilities, and Dr. Kayleigh can speak to some of this more, because she's right in the thick of it, but we're seeing a lot of the cases and deaths in long-term care in nursing homes, and so we have to keep working really hard to protect that population.
That far right box is remarkable.
Yeah.
That 45% of the deaths in the United States and 53% of the deaths in Kansas have come from long-term care facilities.
Yep.
I think that's a really important story and really a very staggering statistic. And it's not something I think we see in influenza, but it's clearly true here with COVID-19.
Yep.
I also think there was an article that just came out yesterday that said that those with comorbid conditions are 12 times more likely to die than those without. So it just adds up. The older we get, the more comorbid conditions we have. Unfortunately, I'm now 60. Now, that's actually a good thing. I should say, fortunately, I am 60, but unfortunately, it means that I have more you just have more health problems at 60 than you do when you're 16.
Yeah. It's just dramatic. Next one, Anthony, I think I have one more. Just again, drilling down a little, we've had 3 outbreaks in long-term care facilities in Wyandotte, and people, there's been a lot of press around some of these, and we feel like we're doing a better job now that we're figuring things out. We're getting in there doing repeated cyclical testing. That seems to be helping, and we really want to work together on this. We're actually working with these facilities on the reopening that Dr. Kayleigh mentioned. We're going to work right along with them to develop that plan so that it's safe and that they feel good about it.
When you say cyclical testing, you just go through the nursing home and just test everybody periodically. Is that right?
Yep.
How often do you do that?
Well, there's not clear guidance, and I don't think we know exactly what the right answer is, but something around, for us, we've been doing something around a week and a half, about a 10-day cycle.
Okay.
And do you find more?
And you get not surprises, but you find a lot of positives that didn't have, were asymptomatic, for example.
We're seeing less of that. So again, I think something has worked pretty well so that we're not as surprised. Now, we do see a lot of surprises in meat packing facilities and employer-based outbreaks.
Yeah, different.
That's where you see.
Yeah. Probably not quite the same level of infection control as we see in the other as in the nursing homes. And just to say, when you do the cyclical testing, are you doing both patients and staff, or?
That's right.
Yeah,
we're doing both patients and staff.
A lot of effort there, and that's going to reflect kind of a little bit of what we're proposing for some of the university reopenings. Jessica, comments about that information?
Frequently that testing needs to occur. And, the CDC guidance actually suggests that we should be testing all staff every week in all of the nursing facilities everywhere. I know that relies on a lot of, differences in communities and differences in different states, and frankly, availability of testing. And so, as each county moves forward with this reopening plan, I think they're going to have to look at each county and identify the prevalence in that county, and then identify the testing capability, and then frankly balance that with the need to really allow those persons to be able to see their loved ones and match those things together. But the ways in which we have really contained the virus in those facilities, the outbreaks are smaller, and that's because we're doing a better job of testing the whole facility once there's one positive, and then really containing all the positives together and cohorting really everyone that we know is positive, and then continuing to test in order to keep those folks separate and safer for the entire facility.
Comments, Dana?
Yeah, absolutely. I think what she talked about is a great point about having to test all the staff workers. There's a recent publication, I believe it was from a group from Belgium, and what they found is similar to what we found here. Our rate of positivity, or our rate of healthcare workers at the health system who have had COVID-19 is the same or lower than the community. And what this Belgium group, or what this study basically showed, was that for their healthcare workers who were in the hospital where COVID-19 patients were, they were the same or lower than the community, but the highest risk of them having a positive test or having positive antibodies, they were looking at antibody tests, was having a household contact with COVID. And so I think that really we are able to really protect each other and our patients in the facilities. It's once you start moving out into the community that really poses the biggest threat to
that's
that.
right there. And I do want to let the record show that perhaps for the second time in known history, Alan Greiner has on a tie and I don't. That's one of the advantages of COVID. I can win on that finally. Jill, do we have questions from media this morning? And if not, we'll go right to our listening audience.
All right. Tracy says, I have an 18-year-old daughter who tested rapid testing positive on Saturday. 2 days later, 7 members of the family rapid testing. They're negative. Tracy wants to know, how long before we get the daughter tested and she's cleared? How long before the family needs to retest? And is everybody okay?
Boy, there's a lot wrapped up into
Yeah,
that
that's a
question,
lot.
Dana. Let's start with you, because there are some infection control principles we really have to talk about. If one person's positive of a family, how long
Yep.
you really should wait before you test everybody.
Yeah, so I don't know about the rapid testing. Is that probably, I would assume it's probably the PCR rapid testing is what they're
Yeah,
looking
and I think
at.
that's probably the 1 or 2 hour turnaround, which
Yeah.
doesn't have as good a sensitivity as the longer
Right,
test.
so if it was positive,
It's
most
positive,
likely it's
but
positive.
if it's negative,
Yep.
you maybe need to be a little worried.
You know, I think, there has been different numbers thrown out. You don't test positive for 5 days after exposure. There's another backed by a study showing that you can have symptoms 2 days after exposure. So theoretically, you could probably be shedding it 1 day after exposure. I think certainly as the farther you get out, 1 to 2 to 3 to 4 to 5 days, your chance of having a positive if you've been exposed to it is going to be greater. As far as the infection control, this goes back to day one when people and the CDC was talking about self-quarantining versus self-isolation, staying away from people, continuing to clean off high-touch surfaces, using hand hygiene, soap and water, alcohol gel frequently, be isolated away from other members of the family as much as possible, use outdoors now as it's getting nicer out, doing those types of things. And again, there was even a study, I think it was either from Japan or South Korea, that showed a possible benefit of using masks while indoors in the household to help decrease household spread as well.
So any other thoughts to that, Alan?
Well,
'Cause this is a typical contact tracing question in Wyandotte County.
It is,
or in
it
any
is,
county.
and you and I both have experienced teenage daughters, and,
Yes,
and
we
so isolation in the
Good
home.
luck, by the
yeah,
way.
but isolation in the home is important for this family. I think Dr. Hawkinson would agree with that. Even now, with those negative tests and those other family members, try to keep that positive.
Because you've been
case.
exposed, and it may not be positive yet.
It
so
might not be.
It's risky
And
to send them out in the public. You could expose it to others.
I would say that initial case, she doesn't ever need to get a negative test to prove that she's negative. She needs to isolate for the recommended period, and I don't know what county they're in. There's slight variations across the counties, but roughly 10 days past symptom onset or 72 hours after symptoms resolve. But everybody else should stay away from her. Everybody else should be monitoring themselves for symptoms closely, and they're going to need to at least quarantine for a full 14 days from the last time they had close contact with her.
And she needs to wear a mask.
Yeah,
If she's gonna
all
be
the
in that
time.
household. So, yeah, all the time now, because that's an especially dangerous situation. Is everybody safe in how they're going to do? Impossible for us to predict that. It really is going to depend a lot on other chronic health conditions.
Folks want to know what the numbers are here at the hospital.
I don't think we said them this morning. What are we today?
Yeah, so we have 19. I think we had 20 at some point yesterday.
We
did
were
not
20
have
in the
any
afternoon.
deaths,
Yeah,
so
no
we did
deaths,
have a
20 in the
discharge.
afternoon. Yep.
Unfortunately, 7 of those in the ICU and 5 of those are on the ventilator. So our numbers have been pretty consistent for about the past week, I would say.
Yeah, they've gone up from the 10 where we were
Yeah.
hovering to the 8, 15 to 20 range. So it's clear that we have had an uptick in our numbers. We've established sort of this little different equilibrium. I mean, but the equilibrium had been around 30 for a while.
Yeah.
Then it was in the low 20s, then the teens, and down to around 10 or 12. Now we've ticked back up to around 20 again, and we expect to just be there for a while. Hopefully we won't see more unless there's another major outbreak in some other area. We still have the healthcare disparities still really impact us. In fact, if you look at some of the risk factors for COVID-19, it's pretty clear that being African American is a major risk factor. And I think that comes back down to population health and just lower income, closer living conditions, and having to go to work and maybe not having as good infection control or PPE while at work. So, Alan, let's talk a little bit about that because that's a major impact to Wyandotte County.
Yeah, and we've talked about that before here. I think we know that certain populations, minority groups, marginalized, underserved populations, they're at higher risk from poor outcomes from all sorts of diseases and much higher risk of having various chronic diseases. We think a lot of that's driven by what we call the social determinants of health, the places people grow up, the environments they're in, that creates a different risk for all sorts of problems. Some of that is really driven by what we think of as a chronic stress environment. You know, you hear people talk about things like adverse childhood experiences and how those affect people later in life. They're real, and we're seeing them play out with how people respond to COVID. If they've had a life that's different than the next person, that may have influenced how their body's going to respond to this virus, which seems kind of wild, but those are the groups we have to work hard to protect and really be as aggressive as we can at providing help to them, being out there, doing the testing and education with them as much as we possibly can.
Well, I think it's easy. I mean, it sounds so perfect coming out of our mouths as we know what's going on, but the income disparity or racial disparities are real, and if we try to write them off as fake news and things like that, then you're just not recognizing what's real out in the world because we see it played out in so many different ways every day. Jessica, talk to us a little bit about some of that because it's got to be also true in nursing homes. Those nursing homes that don't have as good of an environment and nursing homes that have better environments are going to have different outcomes.
So there's been some data that has come out that larger and more urban nursing facilities are more likely to have larger and worse outbreaks. And I think some of that is related, at least partially, to those socioeconomic drivers of the residents living in those facilities. I also think part of the challenge is that the people who work in nursing facilities are frequently, not always, but frequently, they really are our lowest educated, lowest paid healthcare workers taking care of our most vulnerable patient population in a congregate living setting. And actually, I think that at least partially also sets up the challenge within the facility of containing the virus amongst the entire group of people that enter that building. I will say that absolutely, from the standpoint of residents or patients, those disparities in health are really obvious. And in some of those more urban facilities, we certainly have lower average ages of residents. And that's because of the cumulative effect of those chronic comorbid conditions. And those are the places where we're seeing more deaths.
This kind of thing is very real in our world and in the United States. Jill, another question.
Yeah, Alfred Adu, he's from Ghana. I'm probably saying all this wrong, but he's a doctor, and he wants to know, do you routinely screen all the patients going into critical care, i.e. ICUs?
Yeah, Dana, we routinely screen now every admission at
Yeah,
KU.
absolutely. So we are screening, and we have been doing this for weeks. We talked about this. We are routinely screening every patient that comes in for admission to the hospital. So, of course, ICU. On the floors. We are routinely screening our patients that are going to be undergoing surgery. So we are doing this proactively because we know from a patient safety that if, number one, if you are going for a procedure and you test positive, your risk of complications is much higher than somebody who doesn't. So we are routinely testing our outpatients who are coming in for a procedure, but also any patient who is admitted to the hospital.
Yeah, that's a really important, and we do find positive patients.
We do.
And I don't remember our rate off the top of my head. Do you remember the
But
rate
it,
of people that we
by
find?
last week, we were finding just over 1 a day
Yeah,
of
so-
people who had no symptoms.
Right. So, and that would have been a big impact because we had a couple days, I know, where we had 2 or 3 patients who were scheduled for major surgeries who were positive. We had to cancel those surgeries. So it really does have an impact.
And that doctor actually was from West Africa, so I
Yeah.
just wanted to tell him thank you. Lynn wants to know, why is it okay to pick up grandma, she didn't say grandma, but a relative from a nursing home, but it's not okay for me to go in? I can pick her up, drive her around to a doctor's appointment. Why can't I go in? And the healthcare workers get to go in.
Jess?
I think that's a really good question. I think that's about how we're able to balance the risk and the exposure. And if you pick up your loved one and drive her to the appointment, presumably and hopefully you have been doing all of the right things at home, social isolation and really distancing yourself, watching your own health. And then you perhaps, may expose that loved one. Now, when he or she goes into the facility in current state, they are doing complete physical distancing in the facility also. When people leave their rooms, they're supposed to be wearing masks. And so now, theoretically, we would have contained that exposure to that one patient or resident, rather than coming into the facility, which then actually exposes the whole facility to whomever's coming into it.
On things that, from your standpoint of infection control, how do we handle that question in a larger scale?
It's tough, and as you all know, we've all been learning new things every day, and we're constantly, getting new science, trying to sort that out. Dr. Hawkinson mentioned a study where we're seeing studies get retracted now that we usually don't see that happening because things are getting published so fast in the COVID era that we're not sure of the peer review of those studies. I think people are really interested in understanding how much droplets are spread in different environments, how much they might be actually aerosolized if the ventilation is working a certain way. All that kind of stuff is stuff we're just learning about new things every day. And so I do think we're all thinking, okay, anything that happens out in the world, especially outdoors, is probably a better exposure than an indoor one. Mm-hmm. But how to translate all this into policies and procedures for all these places is super tough. And I know these facilities are struggling, and businesses are too, just trying to sort this all out.
Figure it out. Somebody
keep risk at a
said
minimum.
on this very program a few weeks ago, Jessica, I think this was you, we're building the airplane while we fly it. By the way, I've quoted that and used that line many times now. Most of the time I give you credit, not always. Sometimes I act like it was my own.
Royalties.
Okay, Jill.
Yeah, a lot of people are asking about quarantine after vacation, and Magda writes specifically, what about people coming to her house from Illinois and New York?
All right, Dana, here we
great
go.
question.
Big question. Then we'll turn to see what Wyandotte County's going to say.
Right, and you had your daughter from
My
Illinois,
daughter just
so-
came back from Chicago, and I'll tell you what we did. Here's what we did. She drove. She did not fly. She was with her cousin. They both came back, and both have been doing a really good job at sheltering in place. My daughter's social network was 3 people. Other than that, she was on Zoom and she went to the grocery store. And our nephew's social network was, I think, a couple of folks and kind of the same thing. So they'd done a great job. And so they drove here. We screened them, temperature check, questions, things like that. We did not make them undergo a COVID test. They were asymptomatic. They were feeling good. And we said, okay, listen, you have done all the right things in infection control. They had 2 stops to get gas. They wiped down their hands. They used their masks. They wiped down the pumps, et cetera. So we felt comfortable with that. You just flew down to Florida, which could have been a potential hot spot and back.
Absolutely.
And you did the whole airport thing, and you were wearing goggles and did all the right things, I think. So what is your sense about somebody coming in from New York, Illinois then?
So,
by flight?
my concern is too, and I had this concern even yesterday when I was flying back, is, as I live in Kansas, I'm going to adhere to Kansas mandates. And I even looked at the travel guidance yesterday, and I don't think it had been updated for a little bit. But certainly if I were to come back, and now Florida is mentioned, then I would be quarantined for 14 days from work or anything like that. So I think you have to understand where you live, obviously what state, but what county. I think most counties will probably go along with the overall state mandates for that. So that's important to note. If that were to happen, then I would have to do that for sure.
Yeah. Alan, what do you think?
I think it's a good example of how guidance is changing, right? We do have new recommendations sort of all the time at the state level. We in Wyandotte are in line with the state recommendations, as is Johnson County here in the metro, as far as those travel guidance. But the good practices are probably what your daughter and her cousin are doing in terms of hopefully they were super careful in Chicago, right? And then when they're back, they should take that 14-day period and be careful. They may not fully quarantine, but certainly keeping their distance from others in the family to some extent, doing more things outside, not spending time with 20 friends, but keeping that circle
Right.
small,
Really small.
is really important for a period, because nobody wants to be the index case who brought it to 15 of their
families.
pals.
I think it's that same thing we say every day. This is a balanced equation. You have to determine what your level of risk tolerance is, meaning how much risk are you willing to accept. We can't quantify it for you. We can describe it. We just can't quantify it for you. You have to determine, are you at a high risk or are you at a low risk person for having a bad outcome with COVID, knowing that even that can be a gamble. And so you just have to decide, where's my risk tolerance going to lie, and how am I going to handle that internally, and how will I live with the outcome? And those are the hard questions we're all asking ourselves right now about this disease and this virus. It's tough.
All right, so many questions today. Here's a quick one. Eileen visits at a nursing home. Memory care issues at this nursing home, and the masks are making people irritated and agitated as they try to make them keep them on.
Okay,
Solution?
Jess. Here we go. This is a good one because the memory care units have some special challenges.
Yeah, we have seen a lot of challenges in memory care, and frankly, none of them are surprising. This is a population who clearly needs to be in an area that has a lot of supervision, and most people there are probably not going to be willing to wear a mask. And frankly, most people that are there are really probably not going to follow directions or remember them to stay in their room, and probably need the activities that have been provided over the years. And so there are really special dispensations for memory care. The challenge is, as we balance the risks and benefits, and I know I've said that several times, of everything, we know that the people in that memory care unit are probably the highest risk, frankly, because of the inability to really contain everything in exactly the ABCs right way. That being said, as long as everyone is doing their best, if the residents can wear them, great. If they can't, then we don't want them to be agitated just to wear a mask. And the facilities are getting really creative in ways they can implement, one-on-one activities or very distanced activities whenever possible.
I think this is a thing I tell patients all the time in clinic. I'll be going to clinic here in just a few moments. And at the end of the day, this virus you have to confront head on. And you have to decide, what battles can I win that I want to fight, and what battles am I not going to fight? That's one of them, I think, with a loved one in a memory care unit, and trying to get them to wear their mask all the time, or trying to get the staff to say, tell my mom or dad to always wear the mask. There are battles that you have to fight, and there are battles you have to recognize aren't worth that fight. Making somebody really agitated, making their life harder in a situation like that, where the memory is the challenge, because even remembering to wear the mask or remembering the reasons to wear the mask, if you can't do that, then that's going to be a real challenge, because who wants to wear a darn mask? I have a hard enough time remembering to wear the mask running around the hospital. So I think we just have to recognize there are some things we have to let go in this battle, and some things we try to win on. Ultimately, we are winning, but that's the whole landscape of all people all across the country. There are individual battles that we won't win, and we just have to give ourselves permission to be okay with that.
Okay, long time listener, first time caller, Ross wants to know, will the heat of my car kill the virus on my mask?
Okay, well, the heat on the car, and I'm going to assume that this really means if I leave the mask in the
Yeah.
car, I put it on the dashboard, the sun's out there, getting a little UV light. What do you think, Dana?
Yeah, I think the heat itself, I would probably say no. We understand, we've talked about this before, there was a recipe for reusing N95 masks at one point. It was, I think, putting it in your oven for 160 degrees.
Yeah, 160 degrees for 10 minutes or 30.
Even
yeah.
when we're doing our PCR tests here, our lab people have to inactivate the virus. And so they're putting it, I believe, at like 160, 170 degrees for 45 minutes. So I would say the temperature itself, no. But the UV rays certainly could add to that effect of destroying any virus or any other microbes on the mask. And also, if you're leaving it for a day or two, that virus is going to break down as well. So I think it's going to be more of a consequence of time and plus or minus some of the UV radiation that may be coming.
Not
through
really
from
to
the
get rid of
sun.
heat, because unless your car is getting to 160, 170 degrees while it
Right.
sits out in the sun. So that's pretty hot.
Now, again, if your car's getting to 120, 130, which we've seen some of those temperature scales that it can get in, that may help. But I think it's still going to be more a consequence of the time.
That's what we know
and the
about
UV
surface
radiation.
contamination is that time is the big variable. And unfortunately, it's not as long as we originally thought. Not that the virus can't still be there, but its ability to be infectious is deteriorating rapidly outside once it's on a surface.
Time for 2 quick questions. Lindsay wants to know, if someone has symptoms, is early treatment helpful? How long do you stay at home and stick it out before you get medical care?
Okay, let's hit that one, but we'll turn to all of us for this because it's kind of a little bit different for different groups. But so really, what is the effective therapy outside of oxygen and supportive measures, and now remdesivir and probably plasma?
Yeah, I think those are the main two. That we are still doing study trials for the monoclonal antibodies or the IL-6 inhibitors, some of these other more complex medicines. I think certainly time is important. Not only what drug are we using, but when are we using it? That is certainly important. Again, if I were to be diagnosed, I would certainly want to be given remdesivir if I met the criteria. The criteria for getting plasma is much lower. I would certainly want that as well, and I think sooner is probably better. But again, that also goes to your age and your other comorbidities as well. So I think those are important things.
So I think the big thing is if you get short of breath or you get
Yep.
lightheaded or you start having any palpitations, meaning your heartbeats are a little irregular, you need to get to the emergency room. You have a little mental status change, get to the emergency room. You feel lightheaded or dizzy, get to the emergency room. Because those are signs that things are wrong and we need to get more supportive care, Alan. Any other thoughts?
Yeah, and stay in touch with your healthcare provider. There's lots of people that are going to get symptoms that they can't stay at home, but interfacing with your primary care provider. Most of us in primary care have nursing staff that are trained to answer questions about what's a serious level of shortness of breath and when should you get concerned, and maybe come into the office to get checked out to decide if you need additional testing to find out how severe your case is. Now, if it's a true emergency, right, it's a true emergency.
Yeah,
but
911.
but all of us here in the health system, right, we've got teams that are on call 24 hours a day to answer questions like this. And so stay in touch with your providers, and that'll help you decide too.
Yeah, I think that is great advice. And remembering that 90 to 95% of patients who get this, and maybe more, they stay home. There's a very small percentage of patients who actually come into the hospital. Now, Jess, that may be a little different over in a nursing home.
Well, we are working really hard actually to treat people in place whenever possible. And so, frankly, a lot of the treatments that are required include things that we're used to doing, like oxygen and IV fluids and other supportive care. And until there's a time that we have something to actually, treat these minor cases, we can take care of those things typically in the facility. When people do need another level of care, a higher level of care, certainly that would be the time that we would send them to the facility, to the hospital. That said, I think those rates are quickly dropping as we learn more about what the hospital can do compared to what we can do in the facility, and as we get our resources in line.
So many great questions today. I promise to bring the rest of them tomorrow when we have more time. Final question today is from Raylene, who wants to know, why can't families visit at nursing homes with loved ones outside?
Okay, Jess. What do you think about it, Jessica? What do you think about? I keep saying Jessica. What do you think about outside visiting?
So I think that as we do everything we can to minimize risk, outside visiting is the best way that we can minimize the risk to our loved ones in combination, by the way, with some physical distancing, mask wearing, really good hygiene. And there have been a lot of creative things that we have seen proposed, really, from the national organizations and local organizations that involve creating outdoor spaces. So the answer is yes, I think that's the safest way. I'm not sure that each county or each facility is ready for that quite yet, but I am fairly confident that that is the first way that we will be allowed and able to visit our loved ones.
Alan?
I agree. We're, as you all know, Dr. Calendar, Rich, and I are working on a task force on these things, and that's one of the items we've talked about as when we are reopening, which we hope is very, very soon in some of these facilities. That'll be the first thing we recommend.
So I do. Well, listen, folks, this has been a great discussion today. I want to say a thank you to Jessica Calendar Rich for being here. Alan, always a pleasure to have you back, tie or not. And of course, it's a delight to have Dr. Hawkinson, our Hawkeye, back on the show. We'll try and get all this group back together again soon because we know there's a lot of questions for them. Hey, tomorrow, the impact of homelessness with regard to COVID-19 and how that can end up impacting all of us. Brian Meyer, who's the founder and chief executive officer of the Community Veterans Project, and Dr. Nicole Yadlinski, one of our Department of Family Medicine physicians, who's also an expert on the medical conditions that are unique and common to the military. She's also an Army veteran. I think we'll probably have a broad conversation about that, as well as what homelessness means to the community relative to COVID-19. Hey, you know, a couple other things. We have some photos that are going to wrap up our show today. Some are from Stacy. She shows us that how they stayed safe during a recent trip down to the River Market area. The photos kind of include a family bunny rabbit and some signage. Then, on a more somber note, a few weeks ago, the New York Times ran a headline that Rusty and Paula put on some poster board and put it in their yard, and it was a list of the 100,000 people who had passed away. And I remember reading that and the phrase incalculable loss. COVID-19 is real. We can do things that help us. Remember that the pillars of infection control travel with you no matter where you go, whether it's to a nursing home, to the hospital, to your primary care provider, to Chicago, New York, Kansas City, Colorado, or Florida. And if you really want to stay safe, just remember there's still no place like home. We'll see you tomorrow.